Good day everyone, I'm Dr. Mayuga, first year resident of the Department of Internal Medicine, and I will be presenting a case of Guillain-Barré syndrome after COVID-19 infection. To start off the discussion, coronavirus outbreak started December 2019 and was caused by a new coronavirus detected in the city of Wuhan, Hubei province of China. Target receptor was the ACE2 receptor. Most of the symptoms were respiratory and non-specific symptoms. It was transmitted through respiratory droplets. First case was identified in our country March 2020. Currently, on the time of writing of this case report, there are 218 million cases and 4 million deaths worldwide. And in our country, we have 2 million confirmed cases and 34,000 deaths. A study by Whitaker discussed the neurologic manifestations of COVID, which included loss of taste, smell sensation, headache, stroke, reduced consciousness, confusion, and there were reports of isolated cases of Guillain-Barré syndrome. So we go to our patient. Our patient is SV, a 60-year-old male, Filipino, married, Roman Catholic, residing in Trece, Cavite, and admitted for the first time in our institution due to lower extremity weakness. Our patient was apparently well until 2 weeks prior to admission when he experienced fever and productive cough. Patient tested positive for COVID-19 with RT-PCR and was advised to undergo 14-day isolation. However, in the first week of isolation, patient experienced bilateral lower extremity weakness and numbness, which progressed until completion of the quarantine period, prompting consult and subsequent admission. Patient is a known diabetic and a known hypertensive. On physical examination, patient was GCS 15, oriented to 3 spears, stable vital signs, no facial symmetry noted, clear breath sounds, normal rate, regular rhythm, abdomen was soft, non-tender. Focusing on the neurologic examination, cranial nerves were intact, pupils were briskly reactive to light. Sensory loss was noted, 50% on both lower extremities. Motor weakness was noted for over 5 on both lower extremities. Sensory loss was noted to have a dermatomal pattern. T6 to T9 was at 75%. Below T10 was 50% for light touch. DTRs were hyporeflex. Our diagnosis that time was demyelinating disease, probably Guillain-Barré syndrome secondary to COVID-19 infection. Initial workups for the patient done were as follows. Only remarkable was the potassium of 3.97, which helped us rule out hypokalemic periodic paralysis as the cause of the lower extremity weakness. Plain cranial CT scan was also requested, which was unremarkable, helping us to rule out stroke. The patient was admitted for 4 days. Patient was monitored for progression of symptoms or the lower extremity weakness, but there was no note of progression on all hospital days. EMG and CV studies were done, revealing polyneuropathy bilateral affecting both upper and lower extremities with distal and proximal involvement with signs of generalized demyelination affecting both sensory and motor fibers with some axonopathic changes. No denervation changes was noted. This was the diagnostic exam that helped us confirm Guillain-Barré syndrome is present in our patient. Final diagnosis on discharge was Guillain-Barré syndrome, the acute motor sensory axonal neuropathy subtype secondary to COVID-19 infection. So going on with the case discussion, GBS is an acute and frequently severe and fulminant polyradiculoneuropathy. Pathophysiology is mostly autoimmune in nature and it's rapidly evolving areflexic motor paralysis with or without sensory disturbance. For the case of our patient had sensory disturbance. It's also an ascending paralysis, usually manifesting as rubbery legs and tingling dysthesias, which is both present in our patient. Leg is more affected compared with the upper extremities, and there might also be affectation of the lower cranial nerves, which fortunately was absent in our patient. Most patients with GBS required hospitalization mainly due to the need for mechanical ventilation due to the complication of respiratory depression. TTRs may attenuate or disappear, which was hyporeflexive in our patient. Proprioception may also be affected. And like observed in our patient during admission, the absence of progressions of symptoms means they are in plateau, and further worsening is unlikely in these cases. GBS patients usually have an antecedent infection, usually 1 to 3 weeks before the presentation of the symptoms, usually respiratory or gastrointestinal infection. Theologic agents are as follows. Noted were case reports showing correlation of GBS with COVID-19. This slide shows the pathophysiology of GBS, which mostly involves molecular mimicry, meaning that our own cells attack our own myelin sheath and axon, causing the sensory and motor disturbance in our patient. Available literature summarize case reports on GBS after COVID-19. There are 31 published case reports, and average onset of symptoms was 11 days. Mean age was 57 years old, and diagnosis of GBS was made through cerebrospinal fluid and nerve conduction studies. We did nerve conduction study in our patient, which was consistent with GBS. Available also was a case report by Sedagat et al., which reported a 65-year-old male close to the age of our patient, also a known diabetic, which presented with GBS symptoms 2 weeks after infection, comparing it with our patient who presented symptoms 1 week after COVID-19 infection. They had both AMSAN subtype of GBS. Difference is that their patient was treated with IVIG, which is the mainstay treatment for GBS. Ours was treated with conservative management due to non-progression of symptoms. We can conclude in this case report that COVID-19 is a relatively new disease and respiratory symptoms predominate. But we should also be aware that neurologic manifestations and neurologic sequelae is possible. Studies and reports, as we have discussed, correlated GBS as a sequela and manifestation of COVID-19 presenting 1 to 3 weeks after the onset of infection. This case report would also give us knowledge on the possibility of GBS as a sequel of COVID-19. Therefore, we can watch out on its dangers like respiratory depression and debilitating paralysis. Again, more research and studies are needed to fully correlate GBS with COVID-19. Currently, there is an ongoing study by the UPPGH reviewing the neurologic manifestations associated with COVID-19. This would include 37 hospitals in the local setting. Hopefully, they will be able to include Guillain-Barré syndrome as a neurologic manifestation or sequela of COVID-19. This ends my presentation. Thank you very much for your attention and good day.